of medication errors with MedDRA. My name is Suzanne Shaker, both pronunciations are correct. I will be your instructor for today, and joining me is my colleague, Hannah Eaton. Hannah is an MSSO training coordinator, and she will kindly facilitate our session for this webinar. So we'll start off with some introductions. My name, again, is Suzanne Shaker. I'm a medical officer with the MedDRA MSSO team. I'm based in New Jersey on the East Coast of the United States. And prior to joining the MSSO, I had about 20 years experience in the industry, mainly in the world of clinical research. We will be using the Poll Everywhere tool today for some hands-on exercises in the next part of the webinar. So I do invite you at this time to log on to either the URL link or via the QR code you see on the screen to start off with a few questions, maybe get to know you a little bit better, and give you the chance to test out the tool before we hit the exercises. Okay, so the first question is, where are you joining us from today? And while we wait for a few more pins to appear on the map, just a reminder that the webinar today is scheduled for 2 hours. It will be a bit of instructional review in the first hour, and then we'll have some hands-on exercises in the next hour. We will try to leave enough time at the end for a Q&A session, but please feel free to post your questions as they come to you throughout the webinar, and I'll try to stop at intervals and ask Hannah if we have any questions. So this is always exciting to see the pins pop up on the map, and I'm very happy to see folks from different parts of the region. So thank you so much for your time today and for joining us. Good evening or good morning to you. The next question is, what type of function or role do you play, or plural? So if you have multiple, please feel free to choose as many as apply to you. And I see responses coming in. And it's always interesting to see the cross-functional representation of the industry that we have. So typically, as usual, we have most of our attendees from the PV world or drug device safety. So welcome. I also see coding folks who undergo medical review and data analysis. So thank you all for joining. It's very interesting to see the different folks that we have today with us. And then the next question is, how familiar are you with MedDRA? Because this topic today is one of the advanced topics in use of MedDRA. So medication errors tend to be an advanced topic in MedDRA. I do see we have folks from different levels of familiarity with MedDRA. So thank you everyone for your time today. All right, so MedDRA was developed under the auspices of the ICH. In fact, MedDRA is an ICH M1 standard. It's a multidisciplinary standard, so it is an ICH regulation. The activities of the MSSO, the MedDRA Maintenance and Support Services Organization, they are overseen by the ICH MedDRA Steering Committee, which in turn is composed of different members from both the regulatory world as well as the industry world from different regions of the globe, in addition to WHO as observer. This next slide is our disclaimer and copyright notice. So just like MedDRA is owned by the ICH, the slides that we are presenting are also owned and copyright protected to the ICH. However, you're allowed to use them with the exception of the MedDRA, the MSSO and the ICH logos. And if any changes are made, to please clearly label them and demarcate them and avoid any inference that they were approved by the ICH. The second bullet point is the legal disclaimer of being provided without warranty of any kind. And the third bullet point doesn't apply because we don't have third-party material in this webinar. In today's webinar, we'll be going over some regulatory background for this important topic of medication errors. We'll discuss a few definitions and terminologies on the use of these kind of concepts in MedDRA as they are reflected in the ICH guidance documents. And then we'll share some general principles for coding of medication errors, allow you the chance to test out a few hands-on examples and then conclude with a Q&A session. All right, so we can get started. Now, medication errors are a critical, important problem in healthcare. So they're not only of great importance for the patients concerned, but also have a huge impact on healthcare costs. So in fact, there was a paper a few years ago from WHO, which estimated that the annual cost of medication errors runs anywhere in the vicinity of over $40 billion annually. That's a huge cost to consider. They are the most common preventable reason for adverse events in the product use process, which speaks volumes to the importance of how to capture them correctly. So the key word here is that they are preventable, meaning that they can be actions taken to avoid them happening. And that's where the focus of the regulatory authorities lie. They are very strong supporters of capturing medication errors, but not only capturing them and reporting them, but also identifying the different types of medication errors, understanding why they happened, any contributing factors, any clinical sequelae of these errors. All of this information is very important in understanding the best approach forward for mitigating actions and solutions. So in line with the importance of the topic, MedDRA kept pace with this by expanding the offerings available in MedDRA to accommodate new terms in support of coding different types and causes of medication and product use errors and issues. The guidance documentation also kept pace. So the ICH endorsed guideline for coding that we called MedDRA term selection points to consider was updated with more sections and of course supplemented with the detailed companion document that offers even more guidance on this topic. And even if you think that this topic is only relevant to post-marketing sector, it's actually very important and very relevant for clinical development and clinical studies. So let's talk a little bit about the ICH guidance document. The ICH guidance document is a MedDRA term selection points to consider. And the reason why we call it a term selection document is because when you're coding in MedDRA, what you're doing is finding a term that already exists in MedDRA. So you're selecting a term that already exists in MedDRA that is the closest match to your language, to your verbatim, to your received verbatim or natural language term. And these documents that are ICH endorsed are promote accuracy, promote consistency in term selection, and they are recommended to be used as the basis for your individual organization's coding conventions. So to give you an idea of what kind of topics relevant to medication errors exist in the term selection points to consider document, we'll see in section 3 different types of scenarios that speak to medication errors, misuse, abuse, addiction, overdose, and off-label use. There is another document that has even more details in it specific to the topic of medication errors, and I highly recommend that you take some time to download these documents and review them. And this second document is called the MedDRA Points to Consider Companion Document. It has a lot more examples, a lot more details for product use and medication use, errors and issues, but it's a living document. So the ICH endorsed guide for Points to Consider document is released once a year with every March of version or release of MedDRA. But this companion document is a living document. It's updated based on users' needs. So the most recent version was in September 2024. And here's an idea of the level of details included in the companion document. So you have quite a large number of pages and examples dedicated to medication errors. And I want to take just a few minutes to show you where you can access these. So this is the MedDRA.org website. And if you go to, there's more than one way to find these documents. So there's a quick link on the top right under PTC, which stands for Points to Consider, or under How to Use and Support Documentation. They will take you to the same spot. So let's go with the quick link. it will take you to the blue ribbon defaulted open where the ICH endorsed guidelines exist and are housed. So you don't need a MedDRA username or password to access these documents. You can simply download them at whichever type of document or format of document that's easiest for you to use. So let me take you back to the slides. And to tackle the topic of medication errors, I think it's very useful and important to understand a few definitions. Now, MedDRA itself, even though it's called a MedDRA medical dictionary, it's not really a definitions dictionary. So MedDRA does not offer medical definitions in the typical sense, but we do offer something called concept descriptions. And concept descriptions basically describe how a concept or a term is to be approached for context of coding within MedDRA. And when we think about medication errors, some of the issues that we need to prioritize when we think about medication errors is that they are unintentional, as they are described in the concept description, and they are preventable. So those are two main features in medication errors: unintentional and preventable. Of course, they may cause harm, so they may be associated with clinical sequelae, but they always occur in the control of the healthcare professional or patient or consumer during the process of the medication use. So that time frame is when they occur. Those are the medication errors, and they can occur throughout different stages of the life cycle of the medication use. So they may be prescribing errors or communication errors or labeling, packaging, compounding, dispensing, distributing errors, administration errors, monitoring errors, and so on. There is a nice cheat sheet offered in the PTC document that kind of walks you through a few questions you can ask yourself to have a starting place of how to best code these type of scenarios. So there's three main questions you're going to be asking yourself when you receive a scenario that talks about a potential or possible medication error or product use issue. The first question is, did the scenario happen because of an intentional or unintentional step? So was there something or an intentional decision that led to this scenario or not? And as you see in the first column here, so the misuse, abuse, and addiction concepts are all intentional. So is off-label use. But medication errors, like we said in the concept description, they are unintentional. So when you think about the first question of any scenario you're looking at, you're going to be asking, was this intentional? The second question is, who's the person who triggered this scenario? For misuse, abuse, and addiction, it's always the patient and the consumer. It's never the healthcare professional. For off-label use, it's always the healthcare professional. It's never the patient or consumer. But medication errors can be both. So it can be triggered by the patient or consumer themselves. It can also be triggered by the healthcare professional or healthcare provider. Your third question is, was this use within the framework of a therapeutic intention? So was it a therapeutic use or not? Now, off-label is always therapeutic. Medication errors is always therapeutic. And then you have terms like abuse, addiction, and misuse. They typically tend to be non-therapeutic when it's abuse or addiction. But the misuse for purposes of applying codes for misuse in MedDRA, the understanding is that it was done for a therapeutic purpose. And there's this asterisk here, just to kind of get you thinking that this may be not the same in certain regions of the world. There are certain regions of the world where misuse can also be non-therapeutic. So before you decide on certain approaches in your data, it's a good idea to reach out to your local regulator or the regulator in the region you're interested in, just to clarify what their approach is or what their stand is for these kind of concepts. Now, this table is available, like I said, in your PTC guideline. It's really interesting to have it available to you when you're looking at scenarios of medication errors. And we're going to be coming back again and again to this in a workflow concept as we move in further slides. But any questions at this time, Hannah?
I am not seeing any questions yet.
Okay, thank you. So let's take a few examples to kind of bring these concepts to a clearer place in our thinking. This is Lisa, and Lisa is stressed at work. So her doctor prescribed her one tablet of a specific medication, and last night she was still awake at 3 a.m. because of her anxiety and her stress at work, and she decided she's going to take a second tablet. So if we go back, and let me take you back to the 3 questions. If we think about the first scenario for Lisa, so she took a second tablet, was that intentional? We can say yes, it was intentional. She did it other than how her doctor prescribed it for her. And who was the triggering person who led to this concept? It was Lisa herself. So that's, we have a yes, and now we have a patient consumer. And why did she decide to take the second tablet? Was it because she wants the therapeutic effect of the medication? And the answer is yes. So now you have a yes, you have a patient or a consumer, and you have a yes. So let's go back to Lisa. And that's where we have a drug misuse. So that's how you can kind of think through scenarios when you're trying to code on your own with information you receive by asking yourself those questions. Let's look at a second scenario. So, okay, Lisa is stressed at work, and she decides that she's going to use some online medication that her friend advised her to try. Now, this online medication is actually a painkiller, but she wants to use it to handle her stress and her anxiety and help her relax a little bit. And she starts off with 1 dose. That one becomes 2, and now she's up to taking 4 a day. So in this particular scenario, it is Lisa who is the triggering person. So it's the patient or the consumer. She's doing this intentionally, but she's not using the medication that she bought for its own therapeutic effect. She's hoping to help her with something else. And so this is not really a misuse. This is an example of drug abuse. Let's do a third scenario. Let's say that Lisa has been feeling some complications from the medication that her doctor prescribed. She's feeling drowsy. She can't concentrate at work. So her doctor then decides that he's going to give her an analgesic. He's going to give her a painkiller, and he's giving her this particular analgesic as an off-label use to avoid any side effects from the sleeping tablets. So in this particular scenario, the triggering person who did not follow the approved medication information was actually the doctor, but he did it intentionally, and he did it for therapeutic purposes, for the context of a therapeutic purpose. So in this particular example, that's an off-label use. In our fourth and last example, so Lisa is so stressed at work, she's having trouble remembering things. And even though she wanted to follow the instructions of her doctor, but she completely forgot that she already took 1 pill and she took a second pill. So in this particular example, the triggering person is Lisa. And in this particular example, she did not follow the authorized product information or the prescribed product use as described by her physician, but it was accidental. She didn't mean to do it. And because it was unintentional and for therapeutic purposes, this is a medication error. So that's how we can start thinking of scenarios that we receive, because typically in medication error scenarios, it's a story. You receive a narrative or a story, and it has a lot of information in it. And as you try to pick your way through this information, these questions will help you ascertain which type of scenario you're looking at. Once you ascertain which type of scenario you're looking at, you can then kind of decide within MedDRA where to drill down further. So just to give you a flow chart visualizing these kind of questions that we asked already. So your first question was intentional or accidental. Your second question was who made the decision or who was the triggering factor. So let's say it was intentional and it was triggered by the healthcare professional with the framework of a therapeutic intention. This describes the scenario for off-label use. And within the ICH guidance document, the expert working group who finalized the document for last release and the release before that, they had a consensus that in order to code a scenario as off-label use with the available terms in MedDRA that specifically call out off-label use, the source verbatim itself should mention specifically that this is off-label. So you need to have off-label called out specifically in the verbatim to use the MedDRA terms available that have off-label in them. That's according to the ICH endorsed guideline. So let's continue with the flow chart. Let's say it was an intentional deviation from the authorized product information, but the triggering person was either the patient themselves or the consumer, and that the therapeutic intention was, again, yes. That kind of scenario constitutes a product misuse. So they deviated from the approved product information intentionally, but for therapeutic intention. That was the misuse. If it was not for a therapeutic intention, that's where you get your abuse or dependence terms, which in MedDRA fall under the psychiatric system organ class as a behavioral issue. Now, the first question, if it's not intentional, if it's accidental, whether it's by the healthcare provider or by the consumer or patient, it was accidental and it was for therapeutic intention, and that's where you get your medication error. Okay, so let's give an example. Not every story that you receive will be able to answer all the questions, right? So we keep giving you those reference, that table, that flow chart to reference, but in real life, sometimes you don't have a full set of answers available to you. You don't have the full picture. So if it's not clear whether the deviation was intended or unintended, there are options in MedDRA that afford you suitable LLTs or PTs to code. So if no further information is available and we don't know the background, all we know for this particular example is that for the past month, this particular person has been taking an extra tablet at bedtime. But we don't have enough details to answer the questions. Was this intentional or was this accidental? Did she perhaps misunderstand the instructions, or was it because the doctor prescribed it that way and it was the wrong schedule? Or is she having worsening of symptoms at night and she wants to take the extra tablet intentionally? Or is it because her doctor believes that this is more effective, so he was intentional about it? So we don't have enough details to answer the questions that we go through typically in this particular example. So when we don't have enough information, there are terms in MedDRA that we can describe as quote unquote neutral terms or neutral preferred terms. And these are helpful in situations where we're not sure if the event meets the classification of an accidental or intentional deviation from a therapeutic product information. So we do have product use issue, and we do have an intentional product use issue when you are at least aware that the use or deviation of the use was intentional. All right, so let's give you the flow chart to expand now for those areas where we're not sure, we don't have enough information. And those question marks, the boxes with the question marks, kind of plug in areas where we may not have the full set of information. So if we don't have enough information about the therapeutic intention, but we at least know that the deviation was intentional. So they intentionally deviated from the authorized product information, but we don't know what the intention behind that deviation was, then we have options for intentional product use issue. But if the starting point, if our first question, was this deviation intentional or accidental, is also not known, that's where we can use those neutral terms like product use issue, where very little information is available. And within the browser, you can have different examples of these neutral terms. So they're vague terms, but there may be a bit more information available even for vague terms. So for example, if we know that there was an extra dose given, we don't know whether it was intentional or accidental, and that's the extent of the information. We at least have something to match that particular scenario. So neutral terms in MedDRA are various, and they can provide you with a bit more information that can match the scenario or the story that you have at hand. So if we know that there was a deviation to the schedule, but without too much information, a deviation of the dosage without too much information, a deviation of the dose. And dose and dosage are not exactly identical. In MedDRA, dose is the amount given at one point, and dosage is a bit more broad because it can speak to the scheduling, the frequency, the dose as well within it. So dosage is a bit more broad. And other examples, let's say that it was given to someone who is not the appropriate age for that particular product. We also have neutral terms for that. So I do advise you that even if you have a scenario where you don't have a lot of information available to you, still look for neutral terms in MedDRA that may speak to whatever information you do have in your particular story. All right, so we'll give you a quick demo of the MedDRA browser. And just as a reminder, you do have access to temporary credentials in the chat feature, or you can use your own organization access. And to show you where you can access the browser, so again, we go back to our meddra.org website, and there's more than one way to access the browser and more than one browser, because our legacy browser can be accessed on the top right-hand corner under the quick links for WBB. So if you click the WBB, you get to the legacy login page. And just to show you what that looks like, this is our legacy browser, but there's also a second browser. So if you again go back to home and how to use, so you're on the home page, meddra.org, how to use under tools. Here under related links, you're going to see a link to the new web-based browser. So this was launched, I think it was December of last year, so it hasn't quite been a year yet, but this is a new browser that we're really excited about, and it's a little bit different. When you log into the new web-based browser, you'll notice that the screen is a little bit different because the focus really is on the search. So the interface has been simplified in the new browser, but it has all the same features, all the same functionalities, and all the tools that are offered in the previous legacy browser. And when coding medication errors in MedDRA, you still have the same options as any other coding in MedDRA. And coding can be from the bottom up or from the top down. And just as a quick kind of introduction to coding to any folks who are new to MedDRA, coding in MedDRA, like we said, basically is a selection of a MedDRA term that already exists in MedDRA that is the closest possible match to whatever natural language verbatim you're trying to code. And in the search text, you can look up different terms. So let's say you're trying to code a scenario where the patient took the wrong drug. So if you click wrong and you enter drug and you just click enter, it's going to pull up everything that's available in the browser that has those two words, regardless of their order. And if one of these two words can be expanded to be a longer word, it can look at them as though they are roots of a word. So if I just put WRON, it will still pull up words with wrong. And then it will tell me which level of MedDRA it found them. So there are 27 LLTs with these two words, and there are 3 PTs with these two words. When you're coding in MedDRA, you're always using the lowest level term. That is the term hierarchy in MedDRA that you're using when you're coding. So you're always interested in the lowest level terms when you're coding in MedDRA. So the bottom-up approach is basically, I have a scenario where I know there's a wrong drug, and I want to look at all the different options that have the wrong drug in the browser and pick the one that is closest to my verbatim. The top-down approach is actually a better approach for medication errors. And the reason for that is there are so many ways for these stories and these scenarios to be reported that it's just not possible to capture every single way that the person who is reporting may use the words that they are reporting these kind of scenarios. And it's not possible to introduce every single possible word combinations, but also there could be offerings in MedDRA that match your scenario, but maybe in different wording, or maybe you just didn't realize that it's to that level of granularity. So rather than use the bottom-up approach by looking for an LLT, another way you can look up terms in MedDRA for medication errors is to go into the larger groups where these terms are housed together and kind of drill through them. So the SOCs, or the system organ classes in MedDRA, are the highest level in the hierarchy of MedDRA, and they're the smallest number of terms. There's only 27 system organ classes, while LLTs, for example, reach close to 90,000 in MedDRA. And the medication errors are housed under the injury, poisoning, and procedural complications, because giving a medication is a procedure. So you expand the system organ class by clicking on the plus sign, and then you'll find the different scenarios that we kind of already touched base on. So there's our medication errors, there's our off-label uses and intentional misuses or use issues. We have overdoses and underdoses. So these are all large grouped scenarios. So once you're done with the 3 questions to kind of ask yourself, what is the scenario I'm looking at? Is this a medication error? Is this a misuse scenario? Is this an off-label scenario? Maybe an overdose or underdose? They're here. Under your psychiatric disorders, if you expand that, and under psychiatric disorders not elsewhere classified, that's where you find your substance and addictive disorders. So your abuse, your addictions, your dependency, those kind of terms are here. But I want to focus on the medication errors. So I'm going to take you back up to these high-level group terms. If I know the scenario I'm looking for, so I ask myself those 3 questions about Lisa, and I know that what she's going through is a intentional misuse, I can expand the high-level group term and look for intentional misuse as a high-level term, and then look for the PTs that are available here, and then see, does this match my scenario? So I know that she had an intentional product misuse. She's not a child. There's no device or drug delivery system involved. So let me expand this one, intentional product misuse, and look what kind of LLTs are offered. And maybe I have something that really matches the scenario, that she misused it by changing the dose, she misused by changing the frequency or the duration, or maybe that's all the information I have. Same with medication errors. So if I go back up to the high-level group term of medication errors and expand that, I'll see different types of high-level terms. Still some grouping that I can maybe decide where my best chance of finding the suitable MedDRA term will lie. And here is where it's very important to understand the staging. Like we said, medication errors can occur in different stages of the product use process. If I know what the stage was where the medication error happened, I can select a high-level term that matches that and then find the best MedDRA code. One of the most important stages is product administration errors, because in this stage, the actual error ended up being taken by the patient. So the patient actually ended up taking the medication. So these are very, very important concepts. And as you can see, there's a large number of preferred terms, and each of them houses whatever number of LLTs that can speak to even more detail, because the LLT is the one or the term that is the most detailed. So just to give you an example, here's the standalone product administration error. So we know that was a medication error and the patient actually took it. But if we expand it, if we expand that preferred term, I'm going to see that there's, for example, self administration error, or it was a accidental multiple drug administration. So they took multiple drugs accidentally. Let me take you back now to the slides, and we'll be going over a few examples when we do the hands-on exercises. All right, so another thing I wanted to show you in the browser are the concept descriptions. So take you back to the browser, and if we go up here, so on your on the top of your layout, and you can of course customize the layout as best fits your needs. You'll see the one that looks like a maybe a medical document with the plus sign on it. And if you expand that, that's our MedDRA concept descriptions. If you expand that, it'll take you to this URL for concept descriptions. Now, we said concept descriptions are not medical definitions. MedDRA is not a repository of definitions, but it walks you through how a concept in MedDRA is to be approached, how MedDRA classifies it, and how MedDRA uses this concept. So it walks you through the use of the concept in context of MedDRA coding. And it's really not a lot of terms here. There's like 87, 88 terms maximum in these concept descriptions. So it focuses on very important concepts. So you'll see right off the bat, you'll see abuse, for example. You'll see addiction is in there. So abuse for purposes of being used in term selection and in analysis in MedDRA has to be intentional. So it has to be intentional, it has to be non-therapeutic, and it has to be triggered by the patient or the consumer. So that's an important thing to understand if you're going to be selecting codes in MedDRA that speak to abuse. Well, what about those overdose and underdose high-level group term that we saw? So if we go to O and we look up overdose for the purposes of using overdose as a term selection term in MedDRA or for analysis in MedDRA, overdose is described as a dose that is more than the maximum recommended dose, whether that's the quantity or the concentration. So more than the maximum recommended dose, or if it was described as excessive, then that's an overdose. Underdose, I think you can, already guess that underdose for MedDRA is less than the minimum recommended dose, whether that's quantity or concentration. So if your verbatim, if your narrative, if your source story tells you that a patient received less than the prescribed dose, that doesn't necessarily mean that they received an underdose, because the verbatim has to specifically let you know it was less than the minimum recommended dose. It was less than the therapeutic range for that particular product for it to be described as an underdose. So this is a very nice available reference to you, the concept descriptions. If you are going to be receiving information and narratives and verbatims that speak to medication errors, maybe it would be helpful to just take a look at the way these concepts are described in MedDRA before you start coding. Any questions at this point, Hannah?
Yes, we've got 3 questions at the moment. The first one says, so treatment non-compliance by the patient/consumer should be considered under medication error or misuse?
So non-compliance, I think we can go to the browser itself. So there is an option in MedDRA for treatment noncompliance, and if you look it up in the search field and then you kind of expand the pluses next to it, it will show you exactly where it's being housed. So the noncompliance has it's a multi-axial term, so you'll see that it's linked to two system organ classes. It's primary to general. That blue box means that the primary system organ class is general. The secondary system organ class is injury under that HLT of medication errors, product use errors, and issues. Noncompliance, I think, is a very specific concept. So if you receive noncompliance as a verbatim, you are able to code it accurately in MedDRA. But if it's not mentioned as a noncompliance, that's when you have to ask yourself those questions. So noncompliance itself does exist in MedDRA. Like we said, it is multi-axial, so you will be able to link it as a secondary system organ class to the medication errors. Other questions?
Our next question asks, how should off-label use be coded when it is implied rather than explicitly stated? For example, if a patient is prescribed 300 milligrams of a medication, but the approved dosage is 200.
This is like the $1 million question, right? This is the question that everybody wants to know. I want to know too. Let me show you that just a section. Maybe this is a good point to pull up the actual document. So there's our website, there's our support documentation. Let me take you to the points to consider. It's in section 3. And there's your off-label use, right? All right. Here's exactly what the working group, the expert working group, who are responsible for updating this document, this is the wording that they finalized in the most recent release. Well, not necessarily this past March, but I mean the current version of this document has this wording. So off-label use should only be selected when off-label use is specifically mentioned in the verbatim. For information that is suggestive, and I think that was the question raised, for information that is suggestive of off-label use but not reported, you should attempt to obtain clarification. If clarification cannot be obtained, do not infer that off-label use occurred. So, and I know that this does not fully answer your question because it doesn't really give you the other alternative. So what do I do if I don't have information? This is a point I think that the expert working group may still consider. I mean, please feel free to submit a change request or a question to the MSSO if you have an idea of what kind of terminology would work for both regulators and industry. But in the meantime, the instruction itself advises you get the information if you can. So the first plan of action is get the information if you can. If you can't get the information, then let's go back to the browser. And this is the legacy. This is the new browser. So let's go back to the browser and let's look at options. So again, under the HLGT, medication errors and other product use errors and issues, we said off-label uses and intentional product misuses or use issues. So the scenario is intentional. We know that the scenario is intentional and it goes against the authorized product information, but we don't want to use off-label, right? So what are the options available to you? It's either if you can't use off-label uses, so you can't use any of the terms here that has the off-label, then you have options to maybe consider and investigate as an organization. You have options that this was an intentional misuse, or you have an optional intentional use issue. So in intentional use issue, you know that you went against the authorized product information. It was intentionally done, right? And the decision driving it was the physician. So, you know, how you want to maybe select it, we can't really give you one answer because we don't have that in the ICH endorsed guide, but maybe this is something you can have a discussion with a larger group at your organization and arrive at a choice that best fits the scenario. That maybe there was an intentional use beyond the labeled duration or beyond the labeled indication. Maybe there was a intentional use in unapproved population. Maybe for now this is enough until future versions of the ICH endorsed guidelines speak specifically to that one scenario. So in the event, and this is a general approach, in the event that you have a scenario you're interested in and it's not specifically called out in the ICH endorsed guide, then of course your next step is to do due diligence of the best fits that speak to the scenario with approval of whoever makes those decisions in the organization, and then document it, because you want to be consistent, because consistency is key in analyzing data, in the next future steps. So I'm sorry I couldn't give you a straight up answer because we don't really have that in the ICH endorsed guide, but this is a nice, step by step to make that decision as an organization. You had a third question, Hannah, and then we can continue.
Yes, we've got a question that asks the difference between drug effect incomplete and therapeutic product effect incomplete. They have some confusion between the difference. If you could explain that.
Sure. I want to show you a something here under the MedDRA concept description. Let's talk about the word product. Let's see if I don't think we have. Before I do product, I just wanted to show you dosage and dose, because that was something also some folks had a bit of confusion with. So dosage and dose are a little bit different than each other. Like we said, dose is the quantity at one time, and dosage is a bit of a broader term. But I wanted to show you product. Okay, here's product. So in the context of MedDRA, product can refer to different types of products. It includes drugs, whether it's prescription or over-the-counter. It includes biologics. It includes vaccines, combination products, devices, dietary supplements, whatever. So product is a wider concept. In the examples that you gave me, you said therapeutic product effect, if I remember, but what was it? Effect. Could you say the words again, please, Hannah?
Yes,
Incomplete.
Drug effect incomplete versus therapeutic product effect incomplete.
Okay, so let's see where they link up. So there's your drug effect incomplete, and if I find out which PT it links to, it's the same as therapeutic product effect incomplete, and it's the same as the other LLT. So when the two LLTs join at the same preferred term, that means that they are sibling LLTs, right? They belong to the same medical concept. So from a medical concept perspective, they're not different, but they are offered because if you have an effect incomplete, but you don't know that the product was a drug, then you have an option. So it gives you a coding option when the product being used is either not specified or not known or not necessarily reported to you as a drug. Okay, so let's keep going because I know we have a lot to cover. All right, so we touched base on the MedDRA hierarchy, and we talked about how once you identify what concept you're interested in, you can then drill down from these high-level group terms to find the particular type of scenario you're interested in. Most of them are under the injury SOC. We said the substance is under the psychiatric SOC. And just as an example of these type of different groupings will allow you to capture the specifics of concepts you're interested in. So you have the error, whether it's the wrong drug, the wrong dose, the wrong route. You can capture not just the error, you can capture the stage, whether this was a prescribing error or administration error. But you also have terms in MedDRA available that give you both. They give you the type of the error and they give you the stage of the error. So you can have terms in MedDRA that speak to the wrong drug was prescribed, not just that it was a wrong drug and a prescription error, but it was a wrong drug prescribed. And it's always interesting to find these in MedDRA because it allows you to capture most of the information in one term in MedDRA. Same for example, wrong drug administered. So you have the wrong product administered at the PT level. And one thing that I like to point out is that when the product is administered, actually given to the patient, that's where you find these level of details available at the PT level, not just at the LLT level. And that's why I wanted to kind of bring home that administration errors are really important because the patient actually took the medication that was given outside of the authorized product information. Other examples are intercepted errors. Intercepted errors are errors that didn't reach the patient. So somewhere along the chain of events, someone noticed that there was an error that occurred and stopped it from reaching the patient. And even though these are not typically adverse event terms or adverse reaction terms, they're important to capture and report and include in your analysis. Same for potential for error. Maybe nothing really happened, not even an intercepted error, nothing happened, but somebody noticed a scenario or noticed a situation that could lead to an error. Somebody noticed that there's two medications that sound awfully similar, but they're for completely different indications, and maybe we should have a conversation about that. So that's a potential for error, and these are really important because there's still action that can be done to mitigate the possibility of a future error actually occurring. And then you have situations where you're not really sure whether what happened was an error or not, and that's what we talked about, those neutral terms. So all these different scenarios are covered, are available in MedDRA. It's just where do we find them, like we said. Okay, here's an example. So let's do a hands-on exercise, and the QR code is on the screen. The URL is on the screen as well. But let's activate this poll and ask, if your verbatim says that the dose taken was below the minimum recommended dose in the label, which of these do you think best fits this scenario? So you remember, we talked about how there are concept descriptions in MedDRA that speak to certain scenarios. What is your verbatim telling you? How much information are you getting from your verbatim? Are you able to satisfy a certain description or not? And let me just give it a couple more seconds just to maybe reach over 20 respondents, just so we have a good representation. And if you are having any difficulty accessing the poll, please reach out. We'll try to help you. Okay, so let's take a look at responses. All right, so the majority are talking about underdose, and I'm very happy to see that, because please go back to your concept descriptions, right? In MedDRA, we said a concept description for an underdose in MedDRA is that the dose was below the minimum recommended dose. So we know for sure this was an underdose. The verbatim doesn't say anything about whether or not this was intentional or accidental, so we can't say this was an accidental underdose. And even though you can argue and say, well, this was an error in the drug administration, it's very vague. It's not the best match for the scenario that you have at hand. So, why would we select a vague term if we have one that is closer to the story, if it's a closer match to the verbatim? So one of the cardinal principles of coding in MedDRA, you're trying to look for the LLT that is the closest match to your verbatim, that represents the truth of your story. So that's why drug administration error is not the best match here. And same applies for incorrect dosage, but also another thing about incorrect dosage is that it has the word dosage in it, and it's not dose. So one of the reasons I showed you that concept description differences between dose and dosage, they are not the same. So if your verbatim speaks to dose, please be careful if you're selecting LLTs with dosage, because they are not the same in terms of MedDRA concept descriptions. All right, let's do another one. Inadvertently took excessive dose. Let me activate the poll. And again, you ask yourself, what is the information that I'm seeing? Do I have enough in my verbatim to satisfy a concept description? And I just want the LLT that is the closest match to my source verbatim. So I'm going to give it a few more seconds. I just want a few more people to maybe try out for this one. All right, and let's see the responses. All right, so the verbatim used the description excessive dose. And excessive dose is specifically called out in the MedDRA concept descriptions when it talks about overdose. So yes, this scenario is a scenario of an overdose. Even though the verbatim itself doesn't use the word overdose, that description of excessive dose is enough to satisfy the MedDRA concept description, that this is a scenario of an overdose. So it's not just that the dose was increased. This was excessive. This was an overdose. This was beyond the therapeutic range of that medication. Now, does the source verbatim specify whether this was an accidental overdose? I do see the word inadvertently in the verbatim. So inadvertently means they didn't mean to do it. They did not mean to do it. So there was no intentionality here. So yes, even though the verbatim doesn't necessarily use the word accidental or unintentional, inadvertently does lead you to ascertain that this was accidental. So the correct answer is accidental overdose. I'm very happy to see the majority have picked it. Okay, let's talk about a few principles for coding medication errors. Just as in any coding for any scenario, you want to start with best quality data. So you want to start with a clear input, clear report. And if you are able to, and you have anything ambiguous, and you can query, so that's your first step, is request more clarity. Your second approach is that you want the closest LLT. You want to select a lowest level term, an LLT in MedDRA, that is the closest match to your verbatim. And you want to code exactly what you received. You don't want to add information. You don't want to detract information. So you want to code exactly what you received. And in some cases, that may mean that one term or one LLT is not enough to convey the full picture. So you may need to select more than one LLT. And then the last approach, of course, is only use current LLTs. So non-current LLTs in MedDRA are retained within the browser for legacy purposes. So if you ever used an LLT in the past and you have data coded to it and it was in previous versions of MedDRA, you can still track what happened to that LLT in the browser. It doesn't get removed, but it's not there to allow you to use it for coding. So you can't use non-current LLTs for coding. When it comes to specifically to the scenarios of medication errors, one thing to start with, look at those concept descriptions. There's not that many. There's about 88 or 87 total concept descriptions that we showed you, and many of them are not related to medication errors. So just take a look before you start thinking about scenarios, just to understand how MedDRA approaches this. And of course, your PTC guidance documents, your companion document are huge, huge references. They're really great tools at your disposal. I do encourage you to not necessarily read through the documents because they tend to be large, but when you receive a scenario and you're trying to work through that scenario, take a look in that table of contents for those documents. See if you find something that matches your general story and read that one section and see if it helps you. And of course, you know, because we said some regions of the world, some regulators may have their own stance or their own guidances, it's not a bad idea to always take a look at your local regulator's website or even reach out to them for their own publications on this particular topic of medication errors. Your MedDRA structure and hierarchy are of interest to you. Like we said, if you can identify which area in MedDRA your story belongs in, then you can expand that and look through it a bit more carefully. So the hierarchy in MedDRA is important to you. The placement of the LLT or the PT. If you decide on an LLT or a PT as a code, just follow it through to its system organ class. Follow it through to its different hierarchy, like we did with that. I forgot what it was, but we did that with non-compliance, I think, and we followed it through to see which system organ class it resides in, just to make sure that I'm not taking anywhere where I don't want to go. It's not taking me to a procedure, it's not taking me to something I don't want to code to that. So just follow it through before you commit to it. And then we said the browsing top-down is recommended for medication errors just because it's hard to offer all different possibilities of LLT word structures or LLT options that can speak to all the different ways that natural verbatims can be received. So the top-down approach will give you all the options available in that particular scenario. And then if you have a scenario that fits your story, but it doesn't specifically say that this was for a drug or a device or a vaccine, you may find it under product. So it's perfectly fine to apply LLTs and PTs with product rather than drug or rather than device if one exists in MedDRA that perfectly matches your scenario, because drugs and devices are subsumed in the product concept description within MedDRA. All right, so we're going to go through these general principles for coding medication errors in the next slides in more detail. When to use the PT medication error, when to select more than one term to reflect your story, what do we mean by off-label use, and do we need to capture potential or intercepted medication errors? How do we specify the type of error, the stage of the error? Do we need to capture contributing factors? And of course, never infer a medication error occurred if it's not reflected in your source of verbatims. And then there are scenarios where we have a drug delivery device. Does MedDRA speak to that? So we'll go through these one by one. All right, so even though MedDRA has a PT4 medication error, the recommendation is that we should avoid it because it doesn't really give you much detail. It just tells you that there was a medication error, but it doesn't tell you the type. It doesn't tell you the stage. It doesn't tell you whether the patient actually ended up taking the wrong medication or not, so if there was administration. So even though this is available to you, the recommendation is avoid it unless you have nothing else. And if you do see a specific scenario and you've exhausted your search in MedDRA and haven't found anything suitable, then please submit a change request. We're always happy to review those and expand MedDRA if needed. Here's an example. The patient inadvertently didn't use the medication as prescribed. And don't bother querying us because there's no further information available. That's what you received, right? So the source is telling you, we know something happened accidentally. It didn't follow the authorized product information. We don't have any more details. All we know is that this happened. So in this kind of example, okay, you can use a LLT medication error. It's under the PT medication error. Unfortunately, nothing much can be done about this. When do we split code? And when we say split code, meaning that one single LLT is not really enough to convey the whole story. Sometimes, and oftentimes in medication errors, you have a story, you have a chain of events, and something may have started in the beginning. That's called the originating error. And oftentimes it is followed by additional errors or consequent errors. And oftentimes the story tells you what the contributing factor was. And oftentimes the story tells you there was a clinical sequelae. So in selection of the best MedDRA LLTs, you want to make sure you don't leave information that's not coded. If you don't code them, you can't use them in your data aggregation. You can't use them in their data analysis. So in addition to coding your originating error, you do need to code all consequent errors in the medication use process and any adverse events. So for example, if a prescribing error for the wrong drug is reported and it consequently resulted in the wrong drug being dispensed, and administered, then you need to select LLTs not just for the wrong drug being dispensed, but also for the wrong drug being administered. And of course, any LLTs that match adverse events that resulted. But there is an important reminder that we want to avoid double coding the same error with both a specific description and a general description. So for example, if you want to code that there was a drug prescription error, you don't want to code it twice, the drug prescription error as well as medication error, both of them for the same scenario. You don't want to double code that. So just kind of a reminder that if you find something that is specific in MedDRA, that's enough. You don't also need to add that neutral LLT of medication error or medication issue. Okay, so here's an example. The nurse miscalculated the dose. As a result of that, the patient received 40 milligrams instead of 20 milligrams of the medication. And as a result of that, the patient experienced hypotension. So you have a couple of interesting things happening here. You do have a dose calculation error. So that happened, yes. You also have an increased dose that was administered. So it's very important to capture this, to let MedDRA capture the fact that the incorrect dose was administered. And you also have hypotension. So notice that dose calculation error and increased dose administered are, they're not duplications, one generic and one specific. They are giving you different pieces of the information. So this is not double counting. All right, let's talk about off-label. And maybe I can stop a few minutes, Hannah. I know we have a lot to go through, but I do want to also afford people the chance to ask if anything's not clear so far.
Yes, a couple questions come in. The first one asks, can a physician do an off-label use for herself/himself as well if the physician was also the patient?
That's a very unique scenario. I mean, honestly, if you want to think about it, you can have a discussion with your team and arrive at a consensus for that. But it's like anything else. If you want to self-medicate, I mean, there may be options in MedDRA to self-medicate, but you can't be your own healthcare provider as well as your own patient. I mean, there's that becomes a kind of a jumbled option if you decide to analyze this information as a healthcare provider making a decision or a patient making a decision. But you can look for self-medication or self-administration and maybe select something from there. Anything else?
Our next question asks, is there any term to code the situation where there was no administration of the drug, but twicely the patient was recommended by a doctor to take a drug which was contraindicated to him?
Well, yeah, I mean, that's why you look into the MedDRA browsers, right? So if you go to the browsers, so we said under medication errors, there's different stages. And let me just show you the HLTs. So you're talking about maybe a prescribing error. So if the wrong medication was prescribed, but it never was administered, that's fine. You don't have to capture the fact that there was, administration because it didn't happen. Maybe it was during the preparation phase that the error occurred, right? Maybe it was during the dispensing phase, but there was no administration. So you code exactly what you received in your verbatim. And if the verbatim doesn't specify that the patient received the medication, there's no administration error. But I like to point it out because it's so important. It's so important to capture if it happened, because it meant that the patient actually took the wrong medication. And that's more, that's a flag of more risk to the patient. Another question?
Our next question asks, how do you code medication errors in MedDRA when EDC entries and narrative text disagree? Specifically, which LLT/PT should capture the error itself versus the clinical consequences? How do you handle?
Yeah, I mean, yeah, those kind of questions are really tied to the setup of your databases, right? So they're not really tied to MedDRA itself, but really tied to the setup. For example, some EDC databases have a one-to-one correlation where you have the verbatim can only be linked to one LLT. In safety databases that process narratives, you may have the option to assign more than one LLT per verbatim. So that's the kind of question that you'll need to have internally as a group. Who's receiving the data, who's analyzing the data, who's processing the data, and how is it being linked? So do you have additional open text fields that one database is receiving but not the other? So those kind of questions really don't really tie into MedDRA. Maybe one option is that if you receive a narrative and it has all of this kind of different types of information, maybe you want to split them up if your EDC setup only allows a one-to-one correlation. But really, it's a question that you can have with a larger, maybe cross-functional discussion, both with the folks in data management setting up the database, in folks processing the information, and in folks coding it. Maybe even the folks analyzing it, because they will have really good inputs as to what happens to the data downstream. Okay, so let's go back to our slides, because I do want to give you time for hands-on exercises. And even though I do enjoy questions, I want to give you time for hands-on exercises. So we have to get through these concepts and then do a few hands-on exercises. So let's talk a little bit about off-label. We already showed you this same paragraph in that ICH endorsed guide that said that off-label really needs to be called out in the verbatim to be able to select any of the terms available in MedDRA that has off-label in them. So there are scenarios like that, really good question that was raised where you may suspect an off-label use, but if the verbatim itself does not specifically mention off-label, the instruction or the guidance from the ICH endorsed guide, and again, as a reminder, ICH endorsed guide, the working group who works on these guidances represent both the regulatory bodies as well as the industry bodies. So they have to have consensus as to what makes sense to both of them and what satisfies the need for both of them. All right, so in terms of an example of off-label, let's say the pediatrician decided to use the COVID-19 vaccine off-label. So you see this example where the word off-label is in the verbatim. So the pediatrician made the decision. It was an off-label use. It was for a 10-year-old high-risk patient, although this particular drug or vaccine was not yet approved for this particular age group in this region. So does this verbatim fulfill the criteria for classification as off-label? So it was intentional because the decision was made by the healthcare provider. So it was an intentional decision by the healthcare provider, and it was in the context of therapeutic consideration. So he wanted to protect this 10-year-old high-risk patient from this infection. And we're told that he decided to use the COVID vaccine off-label, meaning that the vaccine is approved for immunization against COVID-19 infection in that respective country, but not for this particular age group. In this particular scenario, yes, we have satisfied the scenario of an off-label as well as the ability to use the word, the MedDRA terms that have off-label in them. And if we look in that HLGT4 off-label, we'll see examples where there's certain level of details that can be included in the LLT. So we see, for example, off-label use in unapproved age group. It does offer that level of granularity, and it resides under the PT off-label use. So in this particular example, yes, we can. Let's talk a little bit about potential. Potential medication errors are not errors that occurred. So it did not really happen, but there's potential for a medication error to have happened. And such incidents should also be captured. They also need to be coded to MedDRA because it's important to identify them. And the reason that they're important to be identified and coded is because that's where you want your policies to kick in to identify any mitigation plans to prevent them from happening. So MedDRA has these two kind of generic PTs, circumstance or information capable of leading to medication error, and circumstance or information capable of leading to device use error. So your first question is, what is the type of potential error if there's no that could have happened. And let me just show you in the browser. So we said circumstance, right? Okay, and these are under that HLT of not elsewhere classified, medication errors, product use errors, and issues not elsewhere classified. So it's under this one, this HLT. And if you expand them, you may or may not have a few LLTs with a bit more detail. So maybe you have the potential for medication error. Maybe you know that they could have received the wrong dose. They didn't, but they could have received the wrong dose. They could have received the wrong drug. They could have received the wrong route. So sometimes you have this level of detail. But this next point here on the slide is that if that level of detail of what could have happened is not available in one of your LLTs, the recommendation by the ICH endorsed guide is to please capture what is the type of potential error that could have happened. So for example, let's say wrong strength. They could have received the wrong strength of the medication, but that LLT does not exist. You can capture a second LLT for that particular type. And then another bit of information is the contributing factor. Do we know in the verbatim why that happened? If we have that level of detail, then that's really interesting for the regulator to know, because that's where your mitigation plan comes in. So just remember, you have your potential error LLT, the type of error, like that, they could have received the wrong strength, and the contributing factor all need to be coded. So here's the example. The pharmacist reported that because there's a blurred print on the drug label, that blurred print on the drug label could lead to a wrong dose being administered by mistake. So they were vigilant, they noticed this, and they reported it. And it can be captured, and it should be captured in MedDRA. But remember, you need to capture the potential error. So you have the LLT potential for medication error, and this LLT has the specific type of error, which is the wrong dose within it. So you don't need a separate term for the wrong dose. It's already in it. And you also need to capture the contributing factor. So what happened in this case is that the product label text was illegible, and that falls under product label issue. So contributing factors can be coded and should be coded in MedDRA. What about intercepted medication errors? Intercepted medication errors are errors that did happen, but it was stopped before the patient took the wrong drug. So it was stopped from reaching the patient or consumer. When you want to think about coding intercepted errors, think about the stage where the error happened, not the stage where it was intercepted. So let me give you an example. The pharmacist made the error when she was dispensing the drug, but the nurse identified the error before she gave it to the patient. So the error that happened really was the dispensing part. In the dispensing phase of the product use process, that's where the error happened. So it was a dispensing error, but it was intercepted. So we can qualify it as an intercepted drug dispensing error. And that goes under PT, intercepted product dispensing error. And it does not, we don't need to discuss the fact that the nurse intercepted it, because it already qualified as an intercepted dispensing error. So I hope it's not confusing that when you have an intercepted error and you think about coding it, think about the stage the error happened, not when it was intercepted. So we've been talking a lot about stages of the medication use process, and we said that these stages are really important to kind of maybe assess when you receive your verbatim, when you receive your narrative, because it will help you decide which group in MedDRA you want to investigate further. You want to drill down into and search further for the proper LLT and the proper PT. But as a reminder, some terms in MedDRA capture both the type of the error and the stage of the error. So wrong drug prescribed. Others only have the type of error, wrong drug, and others only the stage, the drug prescribing error. So if you're able to capture both the stage and the type in the same LLT, would be the optimal, if of course that information is known. If the stage is not known in your verbatim, use the terms for the type of error. If the type is not known, but you have the stage, you can use the terms for the staging error. If you can capture both in the same LLT, then that would be ideal because you have as much information in one term in MedDRA. So if you have the stage and the type of error together in your verbatim, look for that in MedDRA options. So if you had the pharmacy dispensed the wrong drug, rather than just say wrong drug and dispensing error as two separate terms, see if you have in MedDRA one LLT that captures both parts of the story, that the wrong drug was dispensed. And there's a lot of those options in MedDRA. Sometimes you do need to select more than one LLT because a combination LLT does not exist in MedDRA. So for example, the verbatim says mistakenly prescribed the wrong strength. So we know that the stage is the prescription, so there was a drug prescribing error, and there was a wrong strength, that's the type, but we don't have an LLT that there was a wrong strength of product prescribed. So that level of combination does not exist in MedDRA. In this kind of scenario, because you have both bits of information, you do need two LLTs to correctly capture all the information that you received in full. And then the contributing factors. So a contributing factor is really the underlying circumstance or the influence or what really happened that played a part in why the error occurred. Because if we can control that, then we can control the risk of the error happening again. So they're really critical to understanding the causality of the underlying causality or the underlying cause of why the medication error happened and how we can identify interventions and mitigation plans that can be taken to prevent the error from happening again. So if you have a verbatim where a contributing factor is provided, please select the matching LLT for that contributing factor. And then if you have in your verbatim consequent error in addition to the originating error, please remember to capture LLTs for the consequent error. Like we said in that, domino effect slide, if you have a chain of events, you need LLTs to capture the full picture because you don't want to leave information on the table. You want to capture the full information in MedDRA codes to be able to use it in your data aggregation and your data analysis. All right, here's an example of a chain of events. The doctor wrote a prescription, and he wrote a prescription for 40 milligrams for this drug X for angina, and it's supposed to be given every 6 hours. But his handwriting is illegible, unfortunately, and the nurse wasn't sure, but she administered the same dose, but for a different drug. And the different drug was a calcium channel blocker, and it was used for treatment of hypertension, but the maximum daily dose is only 10. So the patient ended up taking 40 milligrams, which is an overdose for drug Y, and had a heart attack and died. Not the kind of narrative anybody wants to receive, but a very detailed narrative. It's a very detailed narrative, so there's a lot of information to unpack here. And you can start with the way that it happened. So the contributing factor, there was a prescription that was illegible. So a written prescription was illegible. And that led to the wrong drug being administered. So yes, that also happened. And that led to an accidental overdose, even though the verbatim does not specify the word accidental, but the whole context of the narrative shows you that it wasn't intentional. The patient did receive an overdose, unfortunately, and it was not intentional. It was definitely accidental, even though the word accidental is not there. And this is covered in the ICH endorsed guide, that if you can elicit the fact that it was accidental, it's a very helpful bit of information. What else happened? There was a heart attack, right? So out of this information, which is the contributing factor, is the fact that the prescription was illegible. So it's important to capture that, because this whole thing could have been avoided if we knew that the prescription was illegible, and maybe we can introduce mitigation plan. Maybe we can introduce handheld devices that they can type on rather than notepads to scribble. So the importance of contributing factors cannot be stressed enough. And you notice, of course, there's no death coded here, because death typically is an outcome, and that gets captured in different parts of the database. All right, and then let's move on. Do not infer that a medication error happened unless your verbatim clearly reports it as such. So, for example, the nurse administered 50 milligram of drug X. Well, we can't say that there was a medication error here, because the verbatim doesn't specify that the use was not per the authorized product information. So we can't infer, we can't add information from our end or make inferences. And then, of course, we have scenarios where there are drug delivery devices. So sometimes the prescribing or dispensing the incorrect product or medication happened from incorrect use of the device, or there was a complication during the delivery from the device, or it had something to do with the design of the device or quality of the device, or maybe the device malfunctioned, and it could have resulted in adverse events. So an increasing number of marketed products are intended for use with a drug delivery device, like a combination product that could be co-packaged in a kit or separately distributed, but labeled for use with a specific device. So similar to what we already discussed for medications, safety reports for these products may relate to medication errors, to complications, to device issues, device use issues, or device malfunctions. So as always, if the information is incomplete or ambiguous, of course, clarification should be sought to elicit more information about whether there was a device use issue, device malfunction, or device use error, etc. So here's an example. There was a new design of a pen, and this new design was difficult to activate. So the pen was difficult to activate. The patient pushed the plunger button as hard as he could, but managed to deliver only a partial dose. So again, a lot of information in this narrative, and it's important to break it down and identify how many LLCs we need to capture to reflect the entirety of this story. So we know that there was a device quality issue. The new design led to problems when the patient was using the pen. So there was a device quality issue here, and there was a device use issue here, because the patient was not able to use the device correctly, and this led to a chain of events. So we have a product design issue. It's mentioned in the verbatim. That goes to product design issue. We have that the delivery device component was difficult to use, because it does mention in the verbatim that the pen was very difficult to activate, and it is a delivery device. So the delivery device component was difficult to use. And then a medication error happened, because not the whole dose was delivered. So if you look up in your MedDRA browser the words dose and device, you're going to see options in there for types of medication errors where there was an issue with the delivery of a dose via the device. And in this particular case, it was a partial dose that was delivered by the device. So it was an incorrect dose administered by the device. We don't have an adverse event mentioned or a clinical sequelae in this particular scenario, so we don't have to capture that one. Okay, so before we go into these hand-on exercises, we have a half hour left I want to dedicate to the hands-on exercises, but maybe a quick stop for a couple questions, Hannah, and maybe not all of them if you have a good number.
Great. Our first question we'll start with is, What if the case mentions that a doctor intentionally prescribed a dosage that was over the approved dose? Would that be off-label use?
So if the verbatim, so again with the off-label use, it has to be, so what we said, the criteria, it has to be by a healthcare provider, right? And it has to be intentional, and it has to be for a therapeutic context. So the intention is for therapeutic purpose. Those three satisfy the scenario that this is off-label. But then when you want to select terms in MedDRA that have the word off-label, you have to have the word off-label in the verbatim. So if your verbatim includes off-label, then yes, you can select choices from MedDRA for off-label, because it could be argued that even though it was higher than the therapeutic range, it was after careful consideration of risks and benefits, and they made that decision in the therapeutic context. So if that's clear to you in your verbatim, that's fine. If it's not clear to you in your verbatim and the words off-label are not in the verbatim, then please follow the ICH endorsed guidelines and refrain from assigning off-label MedDRA terms to that scenario. Another question, and then we can get started with the examples.
Great. Our next question is similar. It's about off-label and underdose, that they have a case where you know it's an off-label indication and the dose is also lower than what is recommended. Would you code off-label as well as underdose?
So that's the same kind of thinking, right? So it really depends on what your verbatim specifically says. If your verbatim specifically says that the healthcare provider did this intentionally for a therapeutic purpose, consideration of risks and benefits, and you have off-label in your verbatim, then you are describing an off-label scenario. But if not, then you have to be careful and maybe elicit more information as recommended by the ICH guideline. So if we have more questions, Hannah, maybe we can leave them to the Q&A at the end, and we can do the hands-on exercises. And I'm happy to stay on a little bit more, even if we reach the 2-hour limit, if somebody really wants to stay on and have more questions. But let's move on for purposes of time and start with, how do we start thinking about approaching scenarios of medication errors? So you want to think about the questions that we asked. Was this intentional or unintentional? That's question 1. Who caused it or triggered it? That's question 2. And was there a therapeutic purpose? This helps you decide if you're dealing with medication error, with misuse, with abuse, or with off-label scenarios. And then, of course, you ask yourself, do I know the stage where this happened? Because if I know this was an administration stage or prescribing stage or preparation stage, then I know which grouping term in MedDRA I can drill down into and investigate further. And of course, if there was consequence errors in addition to the initial leading error, then I need to think about these consequence errors to be captured separately. So I start thinking, how many LLTs do I need to capture this particular scenario? And was there any harm to the patient? Did any clinical sequelae happen? If so, I should capture them. And of course, do I have any contributing factors? And then if there was only circumstances reported that could have led to an error, but an error didn't happen, that's my potential error scenario. I still need to code those even if they were intercepted. So even if an error happened, but it was intercepted before reaching the patient. So all of these kind of information will help me guide how many LLTs I need and what is the closest match. So let's start with the first hands-on coding demo. The nurse forgot to administer the second dose of the chemotherapy treatment to the patient. So walking through kind of our thought process. Do we know in the verbatim if this was accidental or intentional? Well, she forgot. So it is information that is known to us that it is accidental. Who triggered this incident? It was the nurse. Was it for a therapeutic purpose? Yes, it was for treatment of the patient. And Do we know what the stage happened? Yes, she forgot to administer. So it was an administration stage. And were there any contributing factors? Not really. Okay, so we have all of this information, and I'm going to give you guys a selection of LLTs and take a look and see which of these do you think, and let me activate the poll, sorry. All right, so the poll is active now. Which of these, maybe one or more, is the best match for the scenario you have at hand? And I'm going to keep the poll open. And again, you have the QR code on the screen. You have the link if you need to access it again, the tool, if you need to access the poll EV tool again. And let's reach maybe 20 or 25 and then show some responses. Okay, so I think we have enough just to show responses. So we have a lot of you thinking this is drug dose omission in error. We have a few with just the drug dose omission. We have a few maybe with temporary interruption, and just maybe a couple for the scheduling daily dose taken less frequently. So let's think this through. Let's think this through, right? The first question we asked is, was this intentional or accidental? And we answered it that this was accidental. And who was the triggering person? This was the nurse, so the healthcare provider. Was this for a therapeutic intention? We said yes. And that cheat sheet table that we said is in your PTC guidance document. That cheat sheet table says this matches the scenario for a medication error. So now I know this was a medication error. My second question is ask myself what stage, because that helps me drill down in my browser. So if I drill down in my browser, I'm looking at this group, the product administration errors and issues, because I know it's an administration stage. So as I look through the product administration errors and issues, I see some of the examples that were proposed, right? The scheduled daily dosing taken less frequently. So it's not really about a schedule. So she forgot to administer the second dose. So it's not really about a schedule. It's about that second dose, that 1 second dose. The drug omission in error seems to match the scenario because she forgot to give 1 dose and it happened in error. It was accidental. Drug dose omission, it's not that it's wrong. It's just, it's not completely reflective of all the information that we have. So the best so far is drug dose omission in error. And if we talk about the drug use for unapproved schedule, so again, we didn't change the schedule. She forgot. So she forgot to administer the second dose. So the best one that really matches the story or the verbatim or the narrative that we have is in fact the drug dose omission in error. So I hope that that's clear for folks. Let's do a second one. Okay, here's a second example. The patient hasn't read the instructions thoroughly, and the patient took his drug twice a day, not just once a day, during the full prescribed 2 weeks treatment duration. So again, let's break it down with the questions. Do we know if this was accidental or intentional? So he took his drugs twice a day, and even though the verbatim doesn't specify accidentally, it explains that he did it because he didn't read the instructions thoroughly. So it was not intentional, and we can infer in this example that it was accidental. And who was the triggering person? This was the patient himself. Was this intended for a therapeutic purpose or a therapeutic context? Yes. And what is the stage that this happened? So he actually took it. It was administration stage. He actually took the drug. Were there any contributing factors? Not that we're clear on. I mean, it just says he didn't read the instructions, but it didn't explain any contributing factors or why. So here's a selection of LLTs. Let me activate the poll. Take a look. and let's see what you guys think. And again, we're looking for the LLT that is the closest match to this story, to this scenario. And let's reach about 20, 25. I know there's more answers, but at 20 or 25, we can get a clear idea of where the trend is. All right, so let's take a look at responses. All right, so we have the majority thinking this is once daily dose taking more frequently. All right, so let's break it down. Let's break it down and see how we talked through this or how we thought through this. The first question was, is it intentional or accidental? So we know that this was accidental. We know it was by the patient, and we know that he did it for therapeutic context. So yes, it was a medication error. We also know it was an administration error. So we're looking at that HLGT of administration errors and issues. And here are some of the LLTs that we kind of put out there as examples of things you can look at. So the extra dose administered is not really a good match because it was not just an extra dose. He did this regularly for about 2 weeks. So that doesn't really reflect the full idea of the story that happened. Now, if we think about, well, it happened over a 2-week period, then yes, it's a schedule. He messed up the entire schedule. We have a PT called inappropriate schedule of product administration. So the schedule was not appropriate. And if we open up that PT, we see so many different example LLTs with a bit more detail, but they all fit under the PT that this was an inappropriate schedule of product administration. So it's important to know that he in fact took this medication outside of the authorized product information. So there was administration. And within that PT of inappropriate schedule, we can find examples of more detailed LLTs. And some of those examples will tell you that the once daily dose was taken more frequently, or maybe once monthly less frequently. Maybe the weekly was more frequently or less frequently. So the LLTs try to give you a bit more detail. And within this selection, I think the once daily dose taken more frequently matches the scenario at hand. So any LLT under PT incorrect product administration duration would be inappropriate because the duration was correct. He was supposed to take it for 2 weeks, but he just took it at the wrong frequency on a daily basis. And he didn't increase the single dose. So he didn't change the dose that he took, but he took it more frequently. And the LLTs under product administration error would be a bit vague. I mean, it's not that it's wrong, it's just not the best choice because it's not giving you the full details of the story that you received. So the reported incident can be captured with a very specific LLT under that PT of inappropriate schedule of drug administration. The PT, the product label confusion, or that there was an issue with the leaflet, it didn't happen here. The verbatim only told you that he didn't read the instructions thoroughly. It didn't tell you anything about the instructions being confusing. So that didn't happen. That's not part of the story. So in this particular example, the best option would be the LLT once daily dose taken more frequently. Let's do a couple more and then we'll open it up for Q&A. Okay, the patient took more than the prescribed dose to get a better drug effect. Let's ask our questions. Was it accidental or intentional? So he did it to get a better drug effect. So we know that he did it knowing what he's doing. So it was intentional. He did it consciously. Who was the triggering person? It was the patient himself. Was that for a therapeutic product? Yes, he wanted the same drug effect. He just wanted to get a better one. And at which stage this happened? So yes, we know the drug was administered. This is important. Were there any contributing factors? Not that we can tell. So what do you guys think of this one? Let me activate the poll. What do you guys think of this one? So he did this intentionally, and he wanted this for a therapeutic effect by taking more than the prescribed dose. Do you think there is an LLT that captures the story with as many details as possible? All right, we're close to 25. Let's open up the responses. Intentional misuse by dose change seems to be the winner. We have folks thinking of intentional overdose or unapproved dose administered. So let's break it down. Okay, so we asked, did he do this intentionally or accidentally? We know he did it on purpose. We know it was done by the patient, and he was hoping for a better therapeutic effect of the drug. So it was intentional product misuse. And if we go into the browser in MedDRA for that HLGT4, medication errors, product use, and product use issues, and the intentional, the off-label and intentional product misuse or use issues. So we offered you a couple of different LLTs to kind of show you how to think things through. This was intentional, and the intentional PTs are typically under the off-label use HLGT, along with off-label use, intentional product misuse, and use issues. If you just say this was a product use issue, it's not enough information. It doesn't really reflect the level of detail that you have in your narrative. And if you say dosage, so we're not talking about dosage, right? So this was the verbatim itself just said that he took more than the prescribed dose, and we said dosage is a bit wider, and it's not reflective of the fact that it was intentional. And the fact that he did take an increased dose and it was administered, that does not reflect the full scope of the picture, the full truth of the story that we received. We know it was intentional. There has to be intentionality, if we can, in the LLT. So the unapproved dose administered is grouped under product use issue. We've got better options for this particular scenario. And the incorrect dosage administered represents a dosage administration issue or error, not intentional misuse. The LLT increased dose administered does not represent the intentional misuse concept. It's a dose administration issue or error. And just as a reminder, we said that the dose is the single quantity. The dosage is a broader concept. It speaks to determination and regulation of size, frequency, and number of doses. So the bottom line is, for this particular scenario, the best choice is, as per the majority of you selected, intentional misuse by dose change, because this LLT specifically calls out that there was intentional misuse as well as the dose change specific type of the misuse. Two more, and we can open up for Q&A. Okay, here's number 4. The doctor prescribed drug A off-label for suppression of preterm labor after careful risk and benefit assessment. So we break it down. Do we know if it was intentional? Yes, the doctor is doing this on purpose, and it was by the physician, so the healthcare professional. It is intended for a therapeutic purpose, and there was a prescription. So this happened during the prescription phase. It doesn't tell us whether the patient took it. So the doctor prescribed this drug for a particular indication, and there are no contributing factors that are mentioned in the verbatim. So let me activate the poll. All right, and let's see, once we reach about 20 or 25 responses, we can share responses at that time. So be very careful when you read the verbatim. Does the verbatim satisfy a certain concept? And can we use certain types of MedDRA terms for capturing this concept? What does the ICH guideline stipulate? All right, we're close to 25, so let me open up responses. Do we have a winner? So the majority are leaning towards off-label use in unapproved indication. Okay, so let's break it down and answer the questions. Was this intentional? Yes. Who was the triggering person? The doctor. Was this for therapeutic intention? Yes. So this matches the scenario for off-label use, and we have that reminder from the ICH guideline that don't use MedDRA terms for off-label unless the verbatim specifies it. But in this case, I do have the word off-label in my verbatim. So I can go to my browser and I can pick from that HLGT on the right-hand side of the screen for off-label uses and intentional product misuses or use issues. So I can be leaning or concentrating on that HLGT. Of course, we offered you LLTs from the different parts, but the LLT drug for unapproved indication. So the drug used for unapproved indication is really vague. It doesn't capture the fact that this was off-label. And my verbatim specifically says off-label. The drug prescribing error is not the best match here. We know this was a conscious decision of the physician, so he's not making an error during his prescribing phase. You might argue that the drug prescribed for unapproved indication may match this, but again, it's really vague when we look at that PT, because that PT falls under drug prescribing issue. But we know this was intentional, and there was other options with intentional, like for example, you have that intentional use for unlabeled indication. This is grouped under intentional product use issue. It doesn't represent an off-label issue. So this LLT could be used, for example, when a patient intentionally decides to take a drug for an unlabeled indication when it's not clear from the report whether this was for therapeutic purposes. So you have that ability to select those kind of LLTs for those scenarios. So the best match in this particular story is an off-label use in unapproved indication, because some LLTs do have that level of specificity. Last one. The doctor mixed up the drug names because they look similar and prescribed the wrong medication. Do we know if this was intentional or accidental? Well, even though the word accidental is not in there, but it's a mix-up. I mean, the verbatim, the story tells you that this was not done intentionally. And the triggering person is the doctor. We know that the context was for therapeutic purposes. And we know that the staging that this occurred was when he prescribed the medication. So it's a prescription phase. And are there contributing factors? In this case, yes, because he got mixed up because the drug names looked similar. So when it comes to selection of LLT or LLTs, what do you guys think? What do we need to capture? What is the best reflection from a MedDRA perspective of this story? And remember, when you have information that needs to be captured in more than one LLT, you can select more than one LLT as long as they are not causing double counting. Okay, so we have enough folks. Let's open responses and see the majority votes. So we do have majority votes for wrong drug prescribed and the drug name lookalike as a contributing factor. So let's break it down. When we asked, was this intentional? The answer is no. This was accidental. He got mixed up. It was the physician who got mixed up, and he was intending therapeutic intervention. So this was a medication error. And we know it was in the prescription phase. So I am interested in the prescription HLT, so that product prescribing errors and issues HLT, but we also offered you different examples from other parts of the hierarchy. So let's review the LLTs proposed in the quiz question. When we said LLT wrong drug as a standalone LLT, so it's really too vague. It could relate to all different stages in the medication use process. And here it was specifically reported during the prescription phase. So we have a better match. We also have the LLT wrong drug administered as an option in the quiz, but that would assume that this error reached the patient. This was not in the source verbatim, so this was not reported. The error may have been prevented from reaching the patient. We just don't know. It's not there, so we can't code. We can't add information, and we don't want to detract information. When we talked about the LLT product confusion, that's a bit vague. It's not that it's wrong, but we have better matching LLTs for that particular scenario under the drug name lookalike LLT. That specifically speaks to which scenario caused the confusion. So your LLT wrong drug prescribed is correct because it captures the stage and the type of the drug error that happened or medication error that happened. And the LLT drug prescription issue is again too vague because we know that the wrong drug was prescribed in error. So in this particular scenario, the best option is to select an LLT for wrong drug prescribed, as well as an LLT for drug name lookalike in here. All right, so we did cover the regulatory background for the medication errors topic. We introduced you to the ICH guidance document and the companion document and showed you where to access the MedDRA concept descriptions as a helpful reference for medication errors. We discussed general principles for coding of medication errors and handled a few hands-on coding demonstrations. And now I can open it up for Q&A. And I know we're very close to the top of the hour, so for folks who want to stay on for Q&A, I'm happy to stay on. And folks who need to drop off, thank you for your time today and hope you found it helpful. Hannah, any questions?
Great. We got a follow-up to the last question we asked. They're still unclear on whether to consider underdose when the indication for which the medication was administered is off-label.
Right. So going back to the instructions in the ICH guidelines. The ICH guidelines will walk you through that off-label if mentioned in the verbatim. So again, it really depends on your source. If it is mentioned in your verbatim that this was an off-label use, that's when you can select MedDRA terms that have the word off-label. If you don't have that in your verbatim and you know that it was an underdose or an overdose, of course that's, and you have it as intentional. I believe MedDRA has intentional overdose and intentional underdose. I think maybe you can look up in the browser and find out. But the second part of your question is, should we capture both? So should we capture it both as an off-label use as well as an underdose or an overdose? I think there are maybe off-label uses where the dose is not the same. So let's see. Well, let's go through the HLGT for off-label. And there's your HLT for off-label. So there's off-label in dosing amount offered as an LLT. And the question now becomes, could this be double counting if we use off-label dosing amount as well as underdose, intentional underdose? Are you reporting the same scenario in two LLTs? And if you're doing that, you may be double counting. So if your verbatim clearly specifies off-label and you have the option for off-label dosing amount, that may be sufficient. If your verbatim does not specify off-label, and then you want to make decisions about the intentional use of the product in a different dose, and you have underdose or below minimum dose in your verbatim, and you want to select it as intentional underdose, then you have an option for that. But selecting multiple LLTs that may risk the fact that you're double counting, because if they reflect the same thing, the same issue, the same error, that is one of the recommended things in the guidelines that we talked about, where it said, don't use multiple LLTs for the same error, for the same information. So it really depends on the verbatim. And you can have a conversation with your team and make a decision on that if those are kind of things that you receive often. I hope that was the answer that satisfied this follow-up question. Any other questions, Hannah?
Yes, we've got two kind of similar questions, again, about off-label, that in most of the spontaneous reports, the term off-label will not be used directly, especially in reports that they are receiving in non-English languages. Can we code it if it can be understood that HCP has done the error intentionally for therapeutic purpose?
Per the ICH endorsed guide, they are very clear on that. They want the words off-label to be used in the source verbatim to allow us the selection of off-label terms within MedDRA. So unfortunately, the ICH guidelines will only tell you that if you don't have that specifically called out in your verbatim, that maybe you want to reach out and elicit that information, see if you can get that bit of detail from the reporter. But for now, for this version of the ICH endorsed guide, that instruction is not there to allow us to assume off-label, even though the verbatim does not specifically call it out.
Our next
Any other questions?
question asks, if we select more than one LLT to better describe the medical error, does that mean we are duplicating the EMS during data retrieval?
So that's a question for data setup, right? So when you're designing your database setup and database extraction, that's a question that you need to have internally on how are you receiving these narratives or these verbatims or these cases for your medication error, and how are you capturing them in whatever database that you're coding in? Do you have the ability to assign more than one LLT per case? And if not, do you need to figure out a way to set it up where you can split them as needed? So that kind of question is not really related to selection of the MedDRA codes and coding, but maybe more to database setup, which could be an internal discussion.
Our next question asks, is overdose defined as per the RSI or just a dose higher than what the patient was prescribed?
So we don't have definitions in MedDRA. What we have are concept descriptions. And if we look at the concept description for the overdose, for the purposes of selection of overdose in MedDRA, and for analysis of MedDRA coded data as it relates to overdose, overdose is described as being more than the maximum recommended dose, whether that's the quantity or the concentration. They also allow for the verbatim of excessive dose. In that kind of verbatim, they do allow it to be described as an overdose. So it's not about the RSI, but if the verbatim specifically calls out the maximum recommended dose or the therapeutic range, then you think about overdose. But if it's higher than prescribed, that's not necessarily overdose.
Our next question asks, therapy cessation by the patient, would you consider that a medication error or should it be considered an action taken with drug?
Well, therapy cessation, I think we have a lot of options in MedDRA for therapy interruption and therapy cessation. So if you look it up in terms of where does it go in MedDRA, it actually goes to the surgical SOC. So that's why one of the guidelines or one of the general approaches was advising you to please follow the LLT and the PT to see where it resides. So this is an example where you have therapy cessation by patients in MedDRA, and if you follow it up, it goes under surgical SOC because it's considered a therapeutic procedure. So it's a procedure rather than an error.
Our next question asks, can we choose medication error if the doctor's error in the diagnosis of the patient's disease leads to the patient's symptoms worsening?
That's an interesting question, but I'm not sure that I agree with that, because the medication errors is within the authorized product information. Now, if the product information stipulates certain indications, and that was the indication that was prescribed for that medication, then there was no error in applying the authorized product information or following the authorized product information, but then there was a misdiagnosis. So I'm not sure if you want to capture it as a medication error itself, because it was giving for the wrong indication, but we could. So if you want to think for, it's an administration, they were given this product and it was intercepted. I mean, you could take a look, but I'm not sure that the story would fall under this particular type of approach, that they did not follow the authorized product information because they had thought they were following it for the right indication. Maybe inappropriate setting. I mean, you have options. You could take a look, but I'm not sure that I agree with it. But again, I mean, you can have a discussion with your team and kind of look through the entirety of the options here and see if they match the story that you have. But again, because they were given under the impression that it was the right indication, I'm not sure it really follows that this scenario resulted in a deviation from the authorized product information based on what you had, the information you had at the time. Any other question?
Great. It looks like we're on our last question for the moment. It says, in the example you shared for splitting terms, can you explain why not overdose?
Why not overdose? I'm sorry, do you know which example?
It just says in the example shared for splitting terms.
Is it this one? No. In the example given for splitting terms. Let me see if I can find that. And if you remember which example it was, please let me know. I'm happy to go back to that slide. No, not this one. I'm sorry, I can't remember which example that you're interested in. If you remember which example, I'm happy to go back to that slide.
I'm not seeing any follow-up.
I don't know if it was one of the questions. Is it this one? Well, the overdose, and let me just take you back to the overdose concept description, because I think that is the answer. Anyway, that's the key to the answer. So an overdose, it's not enough in your verbatim to say that the patient took 2 pills instead of 1, or that they took an increased dose than what was prescribed. That's not enough to qualify as an overdose. An overdose is a unique medical concept. It has to be a situation where the dose is more than the maximum recommended dose. So even if the verbatim tells you they took 3 pills instead of 1, 5 pills instead of 1, you don't know what the maximum recommended dose is. But if they say it was excessive amount of pills and it was excessive dose, then it allows you to assign the MedDRA term for overdose, because the word excessive can't be ignored. It can't be just coded as an increased dose. But if the verbatim simply says they took 2 pills instead of 1 for 2 weeks, that still doesn't qualify as an overdose, because we don't know what the maximum dose for that particular product is, what the safe therapeutic range for that product is. So we can't assume that it was an overdose unless the verbatim has something that really jumps at you like excessive, or it specifically calls out that it was more than the maximum recommended dose. Any other questions, Hannah?
Wonderful. I am not seeing any other questions.
Okay, wonderful. So I think that means we can just share our contacts, our reference information. If anybody would like to send in an email or check out the browsers, these are the links. And change requests, if you have any change requests to submit, these are the links as well for future training schedules and the link to the MedDRA support documentation. You can access us also via social media, and we are very happy to share that we have a new WhatsApp group for US-based subscribers as well. So thank you so much for your time today. I hope that you found it useful, and I look forward to seeing you in future webinars. And thank you, Hannah, for your help.
Thank you, everyone. I'll close the session.